Hello, everyone. Welcome. Um, Welcome everybody to our lovely panel on youth. It's really great to see everyone, although like seeing visually, especially common names and familiar names, just makes you wonder how much we miss being together on this particular event. But just like the theme of this session, which is building resilience in our movement and everything that we do around SIHR and family planning, we're here together, and that's something to be grateful for. So I would like to thank everybody for taking the time to come to our session. I just like to give you a little bit of the tips for this session today. First of all, the session is going to be recorded. And secondly, the chat box is open, and especially the Q&A box is open for to receive any questions throughout the session. So make sure that you drop your question there whenever you feel like you have a question. And for those who are have their mic on, make sure to turn off the notification on your computer so we don't get unnecessary noise. So we'll be having a Q&A session by the end of this session, and where you can raise your hand and ask questions directed to the panelists. We also have a French translation for those who are French speakers. You can actually opt that translation through the button. It's called interpretation down there, and you can select French if you want to have a French translation. So again, I would like to thank everybody for coming. My name is William Otuk. I am a managing director for the for the Young and Alive Initiative in Tanzania, a youth-led organization that is working to scale up family planning and sexual reproductive health for young people in Tanzania. Our session today is building resilience in adolescent and youth sexual reproductive health services. And we have summoned a number of experts and people and young people who are in the field who have been working on sexual reproductive health and rights to actually answer some of the questions, 5 questions on resilience of youth throughout this pandemic, the virus pandemic, through social impact, innovation, and advocacy. So generally how the global pandemic has changed their approach and how it will affect their work moving forward. But secondly, we'll look at youth leadership experiences, as in what is needed to build sustainable organizations and movement, especially in situations like this. But we'll also explore the changes in policies and the concerns that youth have around, across the globe. What has been the progress and what is need to be done even more. We'll also look into what the data tell us. So how are youth faring during this pandemic and overall as it relates to adolescent sexual reproductive health? What is needed to build sustainable system that addresses young people's needs? So we know that the world is facing this pandemic very differently from country to country, region to region, and young people have been affected differently. We all know that lockdowns in certain countries, most of the countries have raised the incidences of gender-based violences, and school closure have led to an increased number of teenage pregnancies and child marriage. We know that countries have lowered their priority in family planning access, especially for young people. And some countries have even gone crazy to even deny the virus as a whole, like my country in Tanzania. But nonetheless, we have to keep moving on. We have to make sure that all young people, especially those vulnerable, can get access to sexual and reproductive health and rights, and especially family planning. So I'm going to introduce the panelists today. The first panelist of today is Sofia Sedinsky. She joined the Gatmaka Institute in 2017. And as a senior global policy manager, her work focuses on advancing sexual reproductive health and rights globally by identifying opportunities to maximize the impact of evidence in policy discussions and advocacy efforts. Previously, Sophia partnered with local human rights defenders to study the role of civil society in the peace process building in Colombia. She also lived for a number of years in Argentina, where she worked with Human Rights Watch conducting regional human rights monitoring and advocacy. Sophia received her master's degree in public policies from the Harvard Kennedy School of Governance and a BA from the Westline Westlife University. We'll also be joined by Dr. Simon B. Mambo, who is a medical practitioner, researcher, and young activist who is passionate about adolescent and youth sexual reproductive health and rights. His daily goal is to make an impact and contribute to the quality of life of young people through advocacy and delivery of health services. Dr. Simon is a co-founder and team lead of Youth Alliance for Reproductive Health in Democratic Republic of Congo, and is working in Uganda at Reproductive Health Uganda as a coordinator of peer educators. We'll also be joined by Mastewa Zenebe Bekele, who is a disciplined woman with humanitarian nature and has experience working with young people and people from diverse cultural and social backgrounds, where honesty and respect is her symbol. Since she was a student, she has been volunteering and engaging in sexual reproductive health and youth peer programs where her deep interest is now rooted. The passion which she has ensured equitable access to sexual reproductive health services has led her to her current advocacy associate role with the International Youth Alliance for Family Planning, in which each of the tasks in that organization have been her priority for the past 2 years and plus. She found herself smiling alone when she came across media dissertation of young people in family planning and media SRHR issues, which she considered to be a main contributor, one of the contributors of the media advocacy in the country. We'll also be joined by Christine Powell, who is a public health and international development specialist who manages research advocacy activities in countries throughout sub-Saharan Africa. As a member of PRB's international program since 2018, Powers leads youth-friendly family planning services, family planning policy research and analysis, and supports partnerships with local family planning advocates to create data-rich communication tools to support policy change. Power joined the PRB with a background in youth SRHR and MCH research, having previously worked with Tanzania German program to support health, the Institute of Reproductive Health and the World Health Organization. Power holds a master's degree in global health from Georgetown University and a bachelor degrees in international relations from Boston University. So without any further ado, I would like to welcome Ms. Sophia for the first presentation. Welcome.
Great, thank you so much, Atuk. Hi, everyone. My name is Sophia Sadinsky, and I'm the Senior Global Policy Manager at the Guttmacher Institute. I first want to extend a big thank you to the organizers, especially to colleagues at the International Youth Alliance for Family Planning, for inviting me to join this great group of panelists and participants today. So I'm going to spend a few minutes setting the scene around the importance of evidence when it comes to building resilience for adolescent and youth sexual and reproductive health and rights. What does the evidence tell us about AYSRH needs? And how can we advance evidence-informed and human rights-based policies to meet those needs moving forward? Next slide, please. So first, I think it's important to acknowledge the immense inequities that existed even before the arrival of COVID. As of 2019, around 14 million adolescent women aged 15 to 19 in low and middle income countries wanted to avoid a pregnancy but were not using modern contraception. This contributed to 10 million unintended pregnancies each year. Now, many young people live in settings that restrict access to safe abortion care, which means that the majority of the 5.7 million abortions each year occur in unsafe conditions. Among the 12 million adolescents who give birth each year, over 5 million make fewer than the WHO recommended minimum of 4 antenatal visits during their pregnancies. And nearly 4 million do not deliver their babies in a health facility. Now, unmet need does not exist in isolation. We know that beyond SRHR, there are an unacceptable number of areas where adolescent and youth needs are not met, and these needs overlap, intersect, and inform one another. This is particularly relevant when it comes to exposure to violence, and I'll talk a little bit more later on about the intersections between rights violations and other barriers to young people's SRHR. Next slide, please. Okay, so that was a snapshot of the situation for adolescent and youth SRHR pre-COVID. How has COVID exacerbated these existing needs? And what are some of the risks if adolescent SRHR is not prioritized moving forward? So earlier in the pandemic, a team of our researchers looked at a range of possible declines in care for 132 low and middle income countries due to COVID-19 disruptions. And I'm happy to share a link in the chat to that analysis later on, which we undertook in partnership with IYFP. These new estimates illustrated the potentially devastating impact that a decline of 12 to 25% in essential care could have on adolescents' SRHR outcomes. They found that for 15 to 19-year-olds, a 12% decline in modern contraceptive use would result in an additional 734,000 unintended pregnancies. A 25% decline in pregnancy-related care would result in an additional 134,000 major obstetric complications and an additional 3,400 maternal deaths. And a 23% shift from safe to unsafe in abortions would lead to an additional 491,000 unsafe abortions. Now, those are projections of the potential impact that COVID disruptions could have. While we won't have a clear picture of the actual extent of the impact for some time, the estimates signal the urgent need for policies that will help avert these kinds of losses. Next slide. Now, those potential impacts to adolescents' SRHR are taking place against the backdrop of multiple intersecting crises that COVID has unleashed, and Otuk signaled a number of these, and I know my colleagues will as well. Now, lockdown measures are disrupting supply chains and the ability to travel to health facilities. School closures are leading to reduced access to SRH supplies and information for adolescents, including critical interventions that are offered in school settings like comprehensive sexuality education. And there have been widespread reports of increases in gender-based violence, child marriage, and other human rights violations. And of course, we all here know that adolescents are not a homogeneous group. The pandemic poses unique challenges for marginalized young people whose rights and needs have long been neglected in data collection and in policy implementation. Next slide, please. But in the face of these compounding crises, we've also seen a number of policies emerge that are supportive of AY-SRHR in the COVID context that I think we should draw from moving forward. And I've just highlighted a few here. These include the WHO's operational guidance for maintaining essential health services during COVID, which includes recommendations for adolescent SRH care. And I think this is encouraging since we all know that many governments often deny the existence of young people's SRHR needs or their sexuality full stop. There's also the new addition of the Adolescent SRH Toolkit for Humanitarian Settings, developed by the Interagency Working Group on Reproductive Health in Crises, which provides strategies to help close the SRH provision gap for adolescents in humanitarian contexts. This toolkit has a wealth of actionable guidance, and I think it'd be really great to see similar toolkits developed for other at-risk or neglected populations. It would also be encouraging to see more national governments using guidance from mechanisms like the COVID-19 Global Gender Response Tracker, which monitors policy measures enacted and highlights responses that have integrated a gender lens, many of which hold relevance for young people. Governments should identify ways to institutionalize service delivery methods that have gained traction during the pandemic, and we've seen a number of these kinds of innovations. These include mobile clinic outreach, patient call centers, and more task shifting to less specialized providers to expand service provision for young people. Adopting some of the positive innovations that COVID stimulated has the potential to increase access to SRH care for adolescents and young people. Next slide. Now, even more concretely in the short and long term, this entails defining and promoting sexual and reproductive health care as essential and addressing supply issues to avoid stockouts, making contraceptives available without a prescription, and facilitating multi-month dispensing of contraceptives. We also need to see the repealing of restrictive policies that hinder adolescents' health autonomy, such as parental consent requirements, and address cost barriers in order to facilitate greater access to these services. And finally, all stakeholders should leverage young people's use of digital platforms to promote telehealth options that make care available to patients in their own home environments. These should all be rolled out with an explicit focus on inclusivity and prioritizing equity in care. Next slide, please. Now, I want to just close by emphasizing that the impact of investing in this care would be immense. And I'm not going to go through all of the impacts on this chart, but I'd be happy to share resources afterwards. So overall, if all adolescent women in low and middle income countries who want to avoid a pregnancy were to use modern contraception, and all pregnant adolescents and their newborns were to receive care at internationally recommended standards, we would see impacts like a drop of 60% in unintended pregnancies and a 63% drop in maternal deaths. And you can see all of those changes if needs are met in the far right column on this chart. Now, recognizing the huge economic fallout that COVID has caused, in addition to being a human rights imperative, it's also worth noting that these are investments that actually provide opportunities for cost savings. In fact, every $1 spent on contraceptive services for adolescents beyond the current level would save $3.70 in the cost of maternal, newborn, and abortion care. Overall, I think we need to consider the long-term policy implications of COVID-19. This pandemic has prompted us to take a hard look at our policies and ask which are serving us and the communities that we care about, and which are causing harm. We have an opportunity to take what all of us here have known for a long time about inequities in access to quality healthcare, which we've seen on stark display throughout this pandemic, and use this to assert what truly good policy looks like as we work towards building greater resilience in adolescent and youth SRHR in the future. Next slide, please. So I'm going to stop it there. I'll leave you with a few links, and I really look forward to further discussion. And now it's my pleasure to introduce Dr. Simon Benzera Mambo, who is the co-founder and team leader of the Youth Alliance for Reproductive Health in the DRC. Thanks so much. Over to you.
Thank you so much, Sophia, for your great presentation. We have seen how the COVID-19 have impacted family planning and sexual and reproductive health services for young people. And now I welcome all participants, morning, good evening for all over the world. I'm glad to be here today to talk about how we can build resilience in adolescent and young people's sexual and reproductive health. I'm Binezera Mambo Simon from the Democratic Republic of Congo, a country which have faced pandemics and haven't left us as young people behind, and we couldn't be invisible from this COVID-19. And how we are going to continue to build the resilience when young people coming together to offer services regarding adolescent sexual and reproductive health. Next slide, please. So adolescent and young people sexual and reproductive health choice is our future. Why? Because as we know, there are many issues to fight against. People are fighting using ineffective approaches, fighting against unwanted pregnancy, maternal mortality rate, unsafe abortion, gender-based violence, female genital mutilation, and other cultural practices, mental health, climate change, to mention about few. These all challenges are still high because the information are not reaching right people, which are young people. And that's why we have seen during COVID-19, the challenges are still increasing. And as Sophia presented to us to see that 10.3 million of unwanted pregnancy and also other challenges were there before COVID-19, which have been worsened even during this year. So next slide. So what do the young people want? What do we need? As young people, we need accurate information about our body. We need to know what's the physiological change we take during our period, what's the change which happened. We need to know about sexuality. We need to know how to handle relationship. We need support from our parents, from partners, from political leaders to support us and to give this information so that we can be able to make the right decisions. Next slide. So as young people, we can see that we reach young people, especially in community where, like in refugee camps, adolescents, young girls do not have little information how they can handle their menstruation. So it is a need of call for all partners, for all political leaders, decision makers, to make sure that young people are receiving information and are not continuing facing the challenges as we are continuing to see. Next slide. So how we can build resilience and why is it needed to build a resilience in adolescent and young people sexual and reproductive health? Because it is part of achieving health for all, and it is part of achieving the well-being of young people and our community. We may not achieve the sustainable development goal if we do not support this powerhouse of young people, 1.8 billion. Imagine putting them in youth corners and we don't provide them services. How are we going to achieve change? How are we going to reach the 2030 when we are not supporting these young people? So when we build resilience, it is all about supporting young people to bounce back from the challenges they are encountering among service providers. They can't access services, they are not supported. But when we build resilience, they are going to see how we can overcome these challenges, and young people will be able to access sexual reproductive services, information, the COVID-19 pandemic or other days. So when we build resilience in adolescent young people, we offer them protection which they face when they access services, and we have that capability to expand the services and also to make them self-resilient as they can make choice about their body and about their health. Next slide, please. So when we build resilience in adolescent and young people, we make sure that we have supported their outcome, and whatever challenges they face, we know that we have helped them to overcome the challenge they face. How we meet the need and aspiration of young people will define our common future, and more chance there is a health development. When we support young people, when they have our support, when we have services for them, when we give them enough funds, we are sure that our future, our goal is going to be healthy, and we are going to achieve the goals where we fix things. Strengthening resilience and developing environments supportive of adolescent young people health and well-being are essential to achieve the health-related sustainable development goals. That's what we are saying. If we are supporting these young people, if we are supporting this young generation of adolescent and young people at this age of 2021, that means in 10 years, when we reach the sustainable development goals as we expected in 2030, the generation we have today, they're going to be healthy, they're going to be able to have the resources they need. They are going to be people who can make decisions because they have been supported, and they won't continue to bring the social cultural challenge and the religion. And that's why we need to support them from today and not waiting tomorrow. Next slide, please. So young people are powerful, young people can give services, young people can deliver. This is the work we are doing in our community. We do not wait to get more fund, we do not wait for political leaders to support us. We say we can go and reach young people because we know what we face, we know the challenges we have. So, and young people are ready to understand, and they understand the fellow young people easily because they are the age meant, and when we are specifically giving the services, we do not have reason to not give service to young people. But we call also the supporters, we call different stakeholders to continue supporting young people. As you can see, UNFPA, IYFP continue to do supporting local and youth-led organization to make sure that they work as peer educators, to make sure that they deliver services when needed. And especially during this COVID-19, where young people couldn't be able to access services because of their cost, because of the family where they stay, because of the many blockage they face. But when they can call their fellow young people, when they can test on WhatsApp and get information, this is essential. So that's why we need to continue supporting young people initiative to make sure that young people are receiving services, and this can be done well when we work with young people. Next slide, please. So one thing we need to also to consider that the meaningful adolescent and youth engagement is needed now. Why? Because when you make sure young people are participating in your programs, that are participating in implementation of any activities from the starting process, you are not going to waste your time, you're not going to waste your money, because they are the one who have planned, they're the one who have told you the needs they need, what the services they need, and how they want to access the services from. So let's engage young people from the start, from the beginning of all planning, so that we can be able to achieve the result we want, than bring them the services which they don't need. And at the end of all, we found some of the commodities, some of the services we bring them, they're expiring when they haven't accepted the services, and the challenge continue to be there when we only see the other generation and forget that young people also the experts who can deliver services. And this will have testify it in my community with also the youth organization I'm leading, that we deliver services, we give services, either short contraceptive, we give information, and we make sure that we get the list that needed. But the problem and the challenge which is still faced, we see only young people as mobilizers, as people who can give information on services. And that's why we have come to say, no, as young people, we have gone to medical school, we have gone to be trained to learn how we can even give short family planning or long-term family planning method. And that's why we are coming. And that's why what we need to be changed, that young people are taken as experts, are taken as service providers, are taken as people who can deliver services. And that's how we make sure that we have built resilience, and we know we are protecting young people to not continue facing the challenges and problems they are facing in this generation. Next slide, please. So why should you support young people? Because if you want change, work with adolescent and young people, and you will see the change you want to see. Adolescent and young people are leaders in improving the health outcome of this generation. As we can see, the epidemiological or the population pyramid of many countries, the majority of the population today are formed by young people. But if you want to improve adolescent and young people's health, we want to improve health for all, we want to achieve universal health coverage, we want to reach to sustainable development goals, and we need to work with young people because they are leaders and they are experts. Young people can directly provide youth-friendly care as well as advocate for youth-friendly practices. We are doing that in our community. We advocate for policy change. We make sure we provide the youth-friendly services, and we have seen change, though we still need support from different partners, different political leaders, from parents, from teachers, and social cultural leaders. Young people take ownership of their own health, and they can access broad sexual and reproductive health services. When a young people is empowered, when an adolescent is empowered, we will make sure he seek for the services he wants to improve his health. But when he doesn't have information, they are going to continue facing the unsafe abortion. We are going to continue experiencing unwanted pregnancy. We are going to see young people facing sexual violence because they don't know even where to go and seek support. But when young people are informed, we take ownership of our services. We make sure that we look for services, and we make sure that we are getting safe services from where we know we can get service from. Youth feel more concerned about and want to engage with activities that are led by young people of their own age. Young people, when they know this is my fellow, we can talk, we can judge, we can talk everything. I make sure that I approach the person, because I won't all go to the old person, elder person to take services when I know there is a fellow person who understands what I'm going through. So young people always feel free, they always feel better, they all feel concerned when they are interacting with their fellow young people. This is why we need to implement, we need everywhere, if it is hospital, if we are providing all kind of provision of family planning services, all corner we are providing SRH services. Let's make sure that young people are there who can offer youth-friendly services. Next slide. Call to action. We are calling as state and non-state orders, we should continuously commit to learn and eliminate the policy and social cultural dilemma that make hard for young people to access services. Let's make sure we shape good policy. Let's make sure the social culture and the challenge young people are facing, we are removing them and we are addressing the issue so that young people can have real information and young people can access services with no dilemma. There is a need to accept and promote sexuality education in and out of school. Accept that youth-friendly services, including free provision of family planning method, we do not work. Young people don't have work, and the majority of countries do not have health insurance where young people can go and buy these services. And the challenge we still face that majority of countries, especially my country, the Democratic Republic of Congo, where services are for pay. So this one need to make sure they are. So next slide. Next slide. So one thing is sure, outbreaks are inevitable, but catastrophic losses for sexual and reproductive health are not. Health inequity kills far more than a single disease like COVID-19. To attain universal health coverage, we need not only to measure the gain in health service coverage, but also to understand the barrier to access the large services gaps that remain. Let's not only measure what we have done, the progress we have made, but let's also see and understand the challenge young people face. Our key message is that young people should be actively involved in addressing their own challenges. Let's involve young people from the start. Let's make sure that young people are served as it's supposed to be. Thank you so much. I welcome all for the Q&A session, and I want to welcome my fellow Sophia Sadiq, Mastuel Zanebe from IYFP Ethiopia. She's going to present about advocacy as a means to build adolescent and young people sexual and reproductive health resilience. Thank you so much for your following us. Thank you so much and keep watching.
Thank you, Dr. Simon. Hello, everyone. Thank you for joining us today. I am Mastuel Zanebe from Ethiopia, working as an advocacy associate with International Youth Alliance for Family Planning. The topic of discussion with me will be advocacy as a means to build IYSRH resilience. Next slide. So in my presentation, we will see RH and crisis, why advocacy is the best solution to create IYSRH resilience, and the advocacy work done by users in Ethiopia with its way forward. Next slide, please. Next slide. The first topic of discussion will be reproductive health and crisis, where I will be discussing how building resilience and integrating RH into the local crisis management would result in higher impact. So when a crisis strikes, the first responders are locals who are already present, familiar with the local norms, fluent in local language, and intimately acquainted with the community's need and resource. So the need to build resilience arises from the fact that locals need to be capacitated and be resilient prior to those crises like COVID-19. There has been a recent increase in effort to integrate sexual and reproductive health into emergency and disaster risk management. Yet, these efforts take a non-linear path. Based on the opportunities and practical experiences observed, they are not going very smoothly. As response capacity is overwhelmed in spite of the preparedness effort, adaptability and flexibility are essential to continuously improve this progress. So advocacy is one of the critical areas for successful integration of sexual and reproductive health into the emergency and disaster risk management by the local government. There are many, next slide, please. Next slide. There are many critical areas such as coordination, partnership, capacity building, advocacy, and leadership for successful integration of sexual and reproductive health into the emergency and disaster risk management. So in the next topic, I will be discussing why advocacy is chosen among the aforementioned critical areas. So just to provide some background, advocacy is putting a problem on the agenda, providing a solution to that problem, and building support for acting on both the problem and the solution. So in this case, we need to identify IYSRH gaps and possible solutions, as well as make them an agenda for policymakers to solve them in a resilient way. Advocacy can result in policy change, and usually it calls for policy implementation using domestic funds, which makes the intervention sustainable. Research has shown that meaningfully engaging users can greatly enhance the reach, attractiveness, relevance, and effectiveness of advocacy on SRH-related issues. This is because advocacy that meaningfully engaged users or young people is more likely to take into account their actual lived realities and to ensure that their needs are and also opinions are reflected in the intervention. Next slide, please. So in the next slide, I am going to take you through an advocacy work
I think we might be having some technical difficulties with Masterwell. I think we're losing her. We'll see if we can get her back, but if we can, is it possible to have our video record on, or should we move on to another panelist? Oh, we have her back. Are you back, Masterwell? Okay.
Yes, I'm back.
Unfortunately,
Sorry.
you're muted. Okay, no problem. Welcome back.
Okay. So I'm going to take you through an advocacy work done in Ethiopia by users. Population Reference Bureau, PRB, and International Youth Alliance for Family Planning, IYFP, implemented a project named Empowering Evidence-Driven Advocacy, or ADA. So Project ADA was implemented in 5 African countries, including Ethiopia. As part of the project, a study which documented the lived experience of young people who access contraceptive service paired with the view and experience of key stakeholders like implementers was conducted in 2018. And the prominent barrier while accessing a user-friendly service, which was outlined by users, was young people to access information, but much of the information on contraceptive in SRH is filled with misconceptions. But those users do have access to medias. Next slide, please. Media is the primary source of information for young people, as outlined by the respondents, but they don't receive enough information on sexual and reproductive health information via those local medias. So on end of 2018, a workshop was conducted with different stakeholders to discuss on how to disseminate the finding of this study and also to design an advocacy objective which can solve cross-cutting gaps. The workshop involved young people and different actors from government and non-government organizations. And as the outcome of the workshop, an advocacy objective was designed to advocate stakeholders in government as well as media to facilitate the broadcasting of SRH information, at least in one of the national medias by 2021. Young people, including me, were also selected to implement the advocacy objective. So multiple in-person and online workshops were organized with different stakeholders from media and government so that we can achieve this advocacy objective. And we are presenting the gaps identified from the study conducted and how the government could do a policy change to address cross-cutting issues via dissemination of user-friendly SRH information on medias. Even when during the pandemic, we continued our work using virtual platforms and following local regulations whenever there was a need to meet in person. So through this, user-friendly SRH information was integrated into a national TV show named Tena Babito, in which the host was one of the targets for our advocacy. And we consider it as a win, even though our advocacy will continue to ensure that user-friendly SRH information is accessible to every user in a sustainable way. Next slide, please. Here is a photo taken at the end of our advocacy workshop with our various stakeholders from government, medias, and also users who are involved. And in next slide, in 2021, we will be following up on 2020 commitments for more tangible policy change. In addition to that, And also, in addition to the mainstream media, which we were targeting in 2020, we will also be advocating for social media inclusion to address the larger segment of the users. And we will be working to cascade the advocacy objective, which was focusing on the central government to regions as well. So I'm done with my presentation. Thank you. Now I will leave the floor to the Christine Power from Population Reference Bureau. I hope you will have a great time with her. Over to you, Christine.
Thank you, Mastawal. Hello, everyone. My name is Christine Power, and I'm going to be concluding the panelist presentations by talking about measuring youth family planning policy environments. Next slide, please. As we've learned from other panelists, meeting young people's family planning needs is a crucial challenge for all countries. And by doing so, countries can help young women achieve their sexual and reproductive health and rights, as well as reap positive economic impacts for their country. In order to address youth needs, countries have institutionalized the rights of adolescents and young people to access health services, including sexual and reproductive health, within formal laws and policies. When we think of family planning policy, we often think of national policies and laws specific to family planning, but family planning policies also extend to essential medicine lists, financing for family planning, and clinical guidelines. Policies often extend beyond family planning and reproductive health and can be incorporated into broader policies on adolescents, youth, health, and development. Next slide, please. Despite decision makers' growing commitment, young people continue to face many barriers accessing contraceptives. Many legal protections, including the age at which a young person can access medical services without formal permission being granted by a parent or guardian, are either not clearly addressed in national laws and policies or are contradicted in many documents. In addition, the policy environment in many countries has not caught up to the commitments that many countries have made in international and regional treaties and conventions. And finally, youth engagement and policy development is limited, meaning that programs and policies are often not responsive to youth needs. Youth perspectives are particularly useful as governments, policymakers, and program planners seek to increase equitable access to family planning for youth in their countries, especially during COVID where access is diminished. Next slide, please. So different policy and program interventions have been proven to increase youth access to contraception. These elements can be used to assess how well policy environments support youth access to family planning and can be used to provide a platform for comparison between countries. But existing measurement tools focused on the policy environment for youth family planning are extremely limited. So to address this gap, PRB has developed a youth family planning policy scorecard to allow for quick assessment to the extent to which a country's policy environment enables and supports youth access to and use of family planning by promoting evidence-based practices. Next slide, please. The scorecard addresses a country's policy environment by reviewing all available country policies relevant to youth family planning and assesses them along these 8 indicators: parental and spousal consent, provider authorization, restrictions based on age and marital status, access to a full range of contraceptive methods, comprehensive sexuality education, youth-friendly family planning service provision, and an enabling social environment. After the analysis for each indicator, the scorecard then assigns a rating to each country, which you can see in the top image on the screen here. The scorecard rating ranges from green, which is a strong policy environment, to yellow, which is promising but with room for improvement, to red, which is restrictive, and then to gray, where no policy exists that addresses this indicator. Next slide, please. So I'm going to take you through a brief summary of the results of our analysis. The analysis of these 22 countries allowed us to take a deeper look at countries' family planning policy environments with some interesting results. So for parental and spousal consent, only 4 countries fully addressed the barriers presented. Many countries only address one party or have policies that are either unclear or contradictory. As for age, all countries except for one supported youth access to family planning services regardless of age, and this is the one indicator where country policy environments were the most supportive. For marital status, while fewer countries had fully supportive policies for youth access, regardless of marital status, there was only one country that had a restrictive policy environment. And finally, for provider authorization, most countries failed to address provider authorization clearly in their policies, which means that the majority of countries do not legally require healthcare workers to provide medically advised family planning services without personal bias or discrimination. Next slide, please. Moving on to the topic of SRH information through comprehensive sexuality education. The discussion of CSE is frequently vague and difficult to access. It will come as no surprise to many of you that this is the indicator that most countries performed poorly on. Our analysis shows that countries often mention sexuality education in their reproductive health policies, but do not have components of a curriculum or guidance on how to implement it. Of the 22 countries that we analyzed, there were 3 that had laws or policies that either promoted abstinence-only education or discouraged sexuality education. Next slide, please. As for youth access to a range of methods, almost half of the countries analyzed explicitly supported youth access to a full range of methods, but 4 of the 22 had policies that restricted youth from accessing a full range of methods. Our analysis showed that policies often restricted method eligibility by age and would specifically note a method that was best for young people or would specifically restrict LARC eligibility to youth. Next slide, please. Of the countries analyzed, there was a mixture of fully supportive and promising policy environments for youth-friendly family planning services. Our analysis looks specifically at training providers to withhold judgment, privacy and confidentiality, and offering services for free or at a low cost. And just over half of the countries analyzed addressed all 3 of those elements. When countries had room to improve, it usually meant that they forgot or failed to address one of the elements or failed to specifically link these elements to youth-friendly family planning. Next slide, please. And finally, for the last indicator, half of the countries analyzed outlined detailed steps to build community support for youth family planning and address gender norms. Countries frequently identified gender inequalities and norms as challenges for youth, particularly unmarried women who wish to seek contraception. Many countries could improve their policy environments by outlining specific strategies to create an enabling environment for youth family planning. Next slide, please. And so finally, with that quick overview of the policy environment in our 22 countries, what's next? The first step is through the scorecard and other tools to ensure that national and subnational policymakers, program staff, and advocates have the information about these relative strengths and weaknesses of their policy environments and how these environments can be improved to better support youth access to family planning. Using the Youth Family Planning Policy Scorecard or other tools, we should ensure that new policy language is tailored to youth needs through country-led accountability. This will help ensure that language alleviates existing barriers to family planning access and promotes a tailored approach to serving adolescents while simultaneously addressing contextual factors. And finally, when feasible and within available resources, it's always helpful to evaluate the implementation of these policies to assess the gaps between policy and the experiences that youth face in their everyday lives. Next slide. And so with that, I'll just say thank you to you all and pass it over back to Otuk.
Thank you so much, Christine, and thank you so much, all the panelists. I mean, we've heard from the data and the movements that young people are building to advocacy, and lastly from Christine to the policies that give young people access to family planning. And I see some of you have already started sharing your questions in the Q&A box and in the chat box. Please keep them coming. Our panelists will be able to answer those questions in the near future. But also, as a surprise, we do have some young storytellers who are going to share with us their experience through stories on how they've been able to build resilience on this difficult time. So I would, without further ado, I would like to welcome storyteller number one. And then just to also add that the storytellers will also be available for to answer any of your questions. So please pay attention, and if you have any questions, you can just drop them on the Q&A box. So yeah, welcome. Yeah, we should have a playback video in a short while. Okay, just a second. Okay, I think it's coming.
Hello, everyone. My name is Jessica, and I would like to share with you a story. Now, I have been a single mother for about 8 years now, and let me tell you, about 9 years ago, I could have never imagined that my life would look like this, the way it is now. I got pregnant when I was 17 years old. I was young, I was energetic, and I was in college. And I got pregnant. Now, my parents had several rules for me growing up, and one of them was do not fall pregnant, out of wedlock first and while you're in school. And that is exactly what I did. Throughout my pregnancy, I was given many instructions on what I needed to do, what I needed to eat, how I needed to act. I was also advised to leave school for a while until I gave birth. Many of these instructions I ignored. I went into labor at around 8 p.m. Started having sharp pains, but I thought it was normal because I'd been having a lot of back pain. And my mom realized that I may be going into labor, and we rushed to the hospital. Now, what I saw on television of, the whole process of labor is definitely not what I was experiencing. On a lot of the shows that I had watched on TV, you get to the hospital and they give you the option of do you want an epidural or not? And then I realized that my country does not offer you an epidural. I don't even know that if we have epidural in my country. So we got to the hospital and I received more instruction on how to lie down. The instruction that I had to walk up and down the hallway every time I had contractions, and the pain got worse and worse and worse. And they definitely do not depict that kind of pain on television. They don't do it right because it was painful. They also tell you that you will forget the pain after the baby comes. That's not true either because I remember the pain. After I had my child, one of my aunties came to sit me down to have a conversation about choice. Now, she presented to me options, and she told me, you've got these various options for you for contraception to make sure you don't get pregnant again. Funny, I was offered the choice after I had already gotten pregnant as a teenager, after I had already missed about 9 months of school. Then I was presented with a choice. And it was very odd for me because that conversation on choice should have come before I got pregnant. Now, I love my child, but I wish I was presented with the choice before. I wish I was presented with the choice to have a child when I was ready to have a child. And because of that entire scenario of getting pregnant as a teenager, having to deal with another human being who slowly started disappearing after, the responsibility of being a parent became a reality. That's my child's father. He disappeared. Um, After experiencing that is when I realized a lot of young women never have that choice, and that choice is only presented to us after the fact. And I decided I'm going to do something about that. And from there, I started learning, and I gathered all the necessary information that I needed. And now, 9 years later, I am an avid, very radical advocate for sexual and reproductive health and rights for young people, because it has not been fair for us to be presented with a choice after the fact, and many today still don't have the choice. And I believe that with the right information, with the right access to all the necessary information and services that we need to make decisions about our bodies, then everything will be better for young people. And I think it is us, the youth, who are responsible for that. So that's my story.
If you walk around West Pokot County in Kenya generally, and you ask if young people know one of the bold health workers that actually has been trying to ensure that even through COVID-19 pandemic, young people and adolescents still access good and effective reproductive health services, including family planning. This name, Angela Tanga, will keep on coming up basically as a bold health worker who went extra mile to ensure that adolescent and young people actually receive youth-friendly and accessible family planning. Eco Project is an initiative that was started by Pathways Policy Institute, basically meaning I know one. To ensure that young people can identify bold health workers in West Pokot County and Laikipia County.
My name is Angela Tanga, a nurse working in Chaparral Sub-County Hospital, South Pokot Sub-County and West Pokot County. I'm the winner of the Eco Bold Health Worker Award. People still don't understand their rights in reproductive health, and thus they don't seek the services fully as it's required. But with the information and knowledge that we are trying to equip to them, they are changing, and we are embracing the numbers that are increasing slowly by slowly. The other challenge is school. Most of the time they will wish to be receiving the services. They're in school and they have to adhere to the school schedules as required. We are engaging the community using our community health workers, and by sending them to schools and their homes to talk to the parents, to talk to the communities and even churches, so that the youth and these young people can get information from wherever they are to come and have services in our facility. As health care workers here, working in static facilities like here, we make sure we have all the information for them and we prioritize them so that they do not see that maybe they've been discriminated. The services are friendly to the youth, because most of our youth are in school, and again most of them come while in uniform, but we identify them when they are in the queue and make sure they are served early and better and fast. The award really motivated me, and I felt that doing something something small makes you great within that time. And actually, I tripled my efforts in working for the youth and even for the other population. Continued motivation from my supervisors and the availing of the commodities and making sure everything is in place so that when, even if there is a crisis or a pandemic of maybe like corona, we still have the gadgets to work, so we feel like we should just continue. I regard it as a call, and so whenever you are placed anywhere to work for the people, make sure you do it fully heartedly.
Hello, this is Karna. I'm from Cote d'Ivoire and I work with Engineer Help since 2019 and currently communication consultant. As soon as I joined the team, I work on an amazing project named Les Femmes Veulent, or What Women Want. So the project aimed to improve knowledge and attitude of population about sexual and reproductive health and also counter misinformation around family planning and safe abortion care. To do so, we decided to work with youth bloggers. So we built a community of youth bloggers with who we co-created a communication and social media strategy in order to promote accurate information about taboo topics like family planning and safe abortion care. Also to promote, to target message about women, girls, and young people. Everything was going well, everything was right on this project. Then the COVID-19 hit. Schools and office was closed, streets were empty, and it seemed that everything stopped existing. The most terrible thing in this was that the sexual and reproductive healthcare was deprioritized in favor of COVID treatment and testing. And also gender-based violence case increased exponentially in the country. I cannot forget the woman who hung from the second floor of a balcony of a building here in Abidjan by her husband. So this one shows us how we were unprepared to prevent GBV and support survival. So seeing this, we decide to shift our strategy. We see that, we recognize that the Ivorians were scared and stressed by all the bad news that they saw on the media. So we decided to launch a communication campaign, a digital communication campaign on social media with friendly message that were also funny message in Ivorianized message, yes. And also we work with youth-led feminist organization like La Ligue Ivoirienne des Femmes, La Ligue Ivoirienne des Droits des Femmes, and the NGO Overcome. So with who we support GBV survival with food, medicine, contraceptive, and legal advice in order that they recover from this pandemic. This was not enough, but it was what we was trying to do. So you see how everything that I see above was not planned. We didn't plan this, but it was what we have to do. because of the situation. We just try to adapt our strategy, and also we continue advocated to the government to include GBV response in the mechanism, in the GBV response mechanism in the national COVID-19 response strategy. Ultimately, I can say that we can all build resilience in several ways and with modest means. Resilient adolescent youth sexual reproductive health program require us to listen to young people like me and our voice, our idea, our perspective. Resilient program also require us to act on what is needed, not what was planned, and what was planned outside of our context, or what people out of our context want us to do. Real resiliency comes when we are open to really listen and when we are not afraid to change course. Thank you for listening my story, and I think that this story will inspire you. Thank you.
Thank you, Karna. I'm going to be sharing a little bit of my story next. My name is Erica. I am 24, and I am many things, but what makes me most proud is the following accomplishments. I'm an educator, a mentor, and a survivor. School principal took a keen interest in chatting with me, hearing my story, and validating my experiences. We continued to meet a few times afterwards, talking about life and goals for the future. She listened to me. She heard my story. There was no judgment, just acceptance. The principal's academic background happened to be in social work, and she explained to me the joys, the challenges, and the heartache that goes into the profession. She told me some of her own personal experiences, which I won't get into today, but how that motivated her to push for change and support those, especially young people, in similar situations. As excited as I was to hear about somebody who had also experienced something somewhat similar in their upbringing, I was also overwhelmed. I didn't have the academic ability to attend post-secondary, I thought. I didn't have the capacity to support other people when I couldn't even support myself, I thought. But what I walked away from those critical discussions was the sheer act of empathy and compassion, what it means to be a support, what it means to be an ally to a young person, and what it means to go above and beyond for someone. So in the months following, I worked diligently to regain and assert control over my life and my future. I ended up returning home. I went back to school. I learned all I could about the field of social work. I saw a therapist. I received support. I persevered. And I ended up completing high school. In fact, I ended up getting into a university, and I even completed my master's degree a year afterwards. I started to become involved in local and national advocacy efforts, and most importantly, I shared my story. And I cannot sit here today and express, a brief version of my story without recognizing the innate privileges I have being a white, cispassing, and able-bodied person. And in this acknowledgement of the privileges and the spaces that I occupy, I have committed myself to a lifelong time of learning, unlearning, and relearning, and sharing and creating space for more young people with various intersections involved in SRHR work. Today, you'll find me either mentoring, in a meeting, organizing, or strategizing how to best include young people in SRHR work. I actively try to engage my peers in conversations around critical youth autonomy and social and reproductive justice. Ultimately, my work isn't about giving speeches, speaking at high-level consultations, or even drafting research articles. My work is about making a tangible impact in young people's lives through support, validation, and therapeutic work. We must continue to utilize our strengths to push forward, to support young people in their innovations, and to never give up hope for equitable sexual and reproductive health and rights and justice, as well as reproductive justice for all. So with that, I just wanted to say thank you all for listening to my story. But thank you as well on behalf of all the other storytellers for letting us share our stories and these lived experiences, as they are so important for building resilience in youth sexual and reproductive health. Thank you.
Wow. Thank you so much, Erica, for sharing your story, and all the other storytellers for sharing their personal stories with us. It takes great courage to be able to share what you have shared with you today. And I'm sure that it kind of like get us into a very good conversation on how you've been able to create resilience even through the difficult times that you've been going through. So we're going to jump directly to the Q&A sessions. And I have a couple of questions on the Q&A box. And I'm going to be reading them pretty quickly. We're running out of time. But I have realized that most people have been answering questions about some of the barriers that young people and adolescents are having when accessing youth-friendly services. For example, there's a question here that says, I attended the faith panel yesterday and heard from multiple youth faith leaders who are unwilling to be able at ICFP that, in essence, they're unwilling to do much to shape the conversation or language around family planning access for unmarried youth. They even said family planning is a controversial phrase, especially in regards to unmarried youth. Without faith leaders, those who so often hate communities, norms, publicly acknowledging youth sexuality, the need for CSE, without language that addresses unmarried youth needs, how have people found the linkages with faith organizations to move the needle on youth access to family planning and reproductive health education and services in communities highly influenced by religion? And one of the members have actually pointed out a country like Bangladesh, where it's actually illegal for unmarried young person to have access to contraceptives. So is there any of the panelists and the storytellers who are in here today want to address that? You're so welcome.
Yes, so good evening again and good morning. What I would want to share about religion and family planning is the fact that religion do accept family planning methods, but now the difference comes to the methods which we need to use, because for them they see as we should be using artificial method only, but are the methods working? If the method are at which percentage are they working? So as family planning movement, as family planning community, and also as people, as Christian, and also as people who believe, the believers, we need also to come together with people's opinion and also the opinion we have to show them if you accept family planning method, because they also want to have the size of the family they want to manage. Now we need only to just appear and see how we can show them that this method they are telling us, if it is natural, it is fine. But how the method, natural family planning work, is not efficient, is not really giving the result which we are wanting, the result wanted. So when we explain, because the more challenge comes all about side effects. And this is also a factor which prevents young people not to have these services. When you explain the method, because there are different methods, now everyone had the best method to use. And this depends also to service providers who provide the services by giving the counseling, because when we start with the counseling and also give counseling enough post family planning counseling, pre family planning counseling, they make people to understand more and know the best method to use. And when this is the issue, we need to address that, to agree which method should the person use. That was my opinion.
Thank you so much, Simon, for that reflection. Is there anyone who wants to also add something before we move on to another question? Well, all right. Thank you, Simon. One of the things that I also saw a lot of participants have been raising is the peer-to-peer program. So, for example, we have a question here that says, it seems relatively easy as a strategy to fund peer educator programs. Why do you think these are not more abundantly funded? Because it looks like the peer-to-peer support is critical and so effective because they have compassion and empathy. So why do you think that these programs do not actually heavily funded? Is there anyone who wants to respond to that? Christine, maybe?
I can start. I'll start and I'll then pass it on to anyone else who wants to add. But at least in terms of the analysis that we've done through the scorecard, when countries are the most supportive around comprehensive sexuality education, it's when they include aspects of peer education as a way to sort of strengthen youth advocacy and civic engagement. I think others on the panel will be better positioned to answer why we don't see it as much. But I will say that in countries where the policy environment is supportive, you see a lot of peer education programs out there.
Thank you so much. We also have one specific question for Sophia. So it says, can you speak more to any policies that emerged during COVID that were supportive of adolescent youth-friendly SRHR and how those can be adapted moving forward?
Sure, absolutely. Thank you for that question. And, I first want to just extend gratitude to our storytellers for sharing their incredibly powerful stories. I'll be quick since I know that we're short on time, and I'd love to hear from my fellow panelists and storytellers on this. I think these kinds of policy adaptations are super important to be looking at because like we've seen throughout all of our presentations, they really underscore how much had been neglected when it came to adolescents' SRHR needs, even before the arrival of the pandemic. And a few examples come to mind for me. I think some of the guidance that we've seen coming out of the WHO's essential services really recommends reassessment of restrictive policies. That came up a lot throughout these presentations as a through line around things that really undermine young people's fundamental right to bodily autonomy around parental notification requirements, restrictions based on cost barriers. And all of us know that these policies are relevant outside the confines of a global health crisis. And so I think we really need to look towards adopting them in the long term. It would also be great to see kind of more coordination between governments and UN agencies around amplifying these supportive policy recommendations and embracing a lot of the innovations that have been driven by grassroots youth activists around peer-to-peer education delivered remotely, WhatsApp channels for youth-friendly contraceptive counseling, virtual support groups. Those have really been shown to expand access and I think should be taken up in the long term and really speaks to the resiliency of youth activists. So I'll stop there, but happy to discuss further and hear from others on the panel.
Thank you so much, Sophia. That was wonderful. We have a question for the storytellers. What recommendations can you give to us, the community of adolescent and youth sexual reproductive health practitioners, researchers, activists, to ensure that we are able to address those real experiences in adolescent and SRHR field? So any of the storytellers want to respond to that?
Thank you, William. So I will answer this. I think that what I can say is for every youth who are working in this field, you have to, as I say, you have to listen your environment and be sure to address the real problem of your community. So, and also there will be always some barrier in front of you on your way. To tackle this barrier, you have to surround you with activists like you, as you can support you yourself. And yes, thank you.
Thank you so much, Karna, for that. This next question is actually my favorite. I've been asking myself this question for like forever. Many promises are being made by policymakers and gatekeepers for youth and youth-led organizations, but are not often followed through. How can young people hold these adults accountable to these promises of funding, capacity building, and greater spaces for youth? Anyone wants to respond to that?
I can comment on that quickly if that's okay. Yeah, amazing. I think it's really important to recognize, especially if you're a young person involved in the space doing youth organizing, that there are also other youth organizing spaces out there as well, right? So in a country as vast as Canada, there are tons and tons of youth organizing spaces. And I think one of the gaps is that's kind of been, aided in these these kind of situations where governments aren't following up, like that's only further exacerbated the difference in the divide between youth organizers and how they've been able to connect. So I think the greatest and biggest thing that folks can do is get connected with other youth organizations or other youth organizers or activists in this sphere to work together and to build coalitions, because our work cannot occur in silos. It really needs to be, a multi-level, at the ground, but also at kind of the highest level initiative, right? And it's also making sure and prioritizing that we are giving space to Black, Indigenous, and racialized folks as well, and putting those folks at the forefront, especially at least in our work in Canada. So it's mostly about, to sum it up, making sure that we have the capacity and giving folks the space to connect with one another, to organize, to build coalitions, because our work can occur in silos, as I mentioned. And yeah, so the real significance of being connected to one another is huge.
Thank you so much. Thank you so much, Erika. We have a question to Master and there's one, what change have occurred in Ethiopia through your advocacy drive through the media upon decision makers at high level? And the question number two is, what are the pros and cons of separating youth-friendly services from the clinic versus integrated ones? And which one is the future?
Okay, thank you, Otuk. I also would like to thank the requesters. It's a wonderful question. I will answer the first question in two ways. The first one is the change that came through the research. The research revealed many gaps in user-friendly services. After we present our findings to the Ministry of Health officials, they told us that they started to arrange sudden field visits and monitorings, in which they will set direction based on the gaps that we outlined, and also they proved from their field visit. The other one is the change that came directly out of the advocacy work. We have got commitments and willingness from media to collaborate with partners and government to disseminate user-friendly SRH messages. Our targeted journalists also disseminate user-friendly SRH messages using their own regular TV show. And also there were issues outlined during our advocacy that journalists are having challenges to get healthcare providers so that they can bring them to their show and they can deliver the fair message to the users. As we all know, journalists are not expected to know what's updated regarding the IYSRH information. So this was solved by the Ministry of Health, because they assigned a body to be communicated in this, as well as they commit to train journalists to update them with the IYSRH issues. The other one is, what is the pros and cons regarding separating YFS from the routine healthcare service. Even in our research, we have identified some cons from separating the YFS from the regular or routine healthcare service, because when there is a separate place for users to provide the contraceptive only, and when the users go to that corner, it will be obvious that they are going to access that contraceptive, and it will have privacy issue for the users. So it contradicts with the concept of confidentiality somehow. So it has some backside, which was outlined by the users. But it's also recommended for the users to get this service by a separate use corner, because when they sit with the people, like with the people who are going to get other services in health care facilities, maybe they need to tell to the facilitator that why they are coming here, and that will also have some confidentiality issue for the users. So it is somehow contradicting, but users explicitly said that they are having some issues by accessing YFS in a separate corner, because it will cause them a confidentiality issue. Thank you. And I will invite the rest of the panelists to reflect on this if they have additional idea.
Thank you so much, Master, for that reflection. And I would like to thank all the panelists and all the amazing storytellers for a wonderful session. We've learned a lot. We've learned a lot from your experiences. And this actually shows how resilient this movement is. And despite all the challenges that we might be facing, whether it's this pandemic, whether it's political pushback, whether it's traditional religious pushback, we believe that we're going to stay strong and make sure that all the young people, all adolescent young people have access to comprehensive sexual reproductive health and family planning. So this marks the end of this wonderful session, and I want to thank once more all the participants who have taken the time to come and join us. I would like to wish you a wonderful morning, afternoon, and evening, and make sure that you can check out all this webinar in both English and French, and all the slides and documentation will be available for your access. Thank you so much, everybody, and have a good day.